Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. He's not slurring his speech. He's not paralyzed. He's not even that confused. But he can't follow simple steps. And that should scare you. Because the most dangerous stroke patient is the one you almost call normal. Welcome back to another episode of Life in Sirens. This is going to be a radio report submission. Real calls from real providers.
If you've got a call, a question, or something that you want us to break down, submit it using the link in our show notes.
This one is going to come from Jasmine out of Louisiana. So let's start with your patient. 65-year-old male, diabetic, complaints just not acting right. Awake, sitting upright, he's conversational, has some delayed responses. He can start tasks, but he doesn't complete them.
He's not altered enough to scare you, but not normal enough to ignore him. Sudden confusion and difficulty understanding are stroke warning signs, not just motor deficits. Okay, now back to our patient. We find that their glucose is normal, their vitals are stable. There's no obvious indications on your FAST exam, your BFAST exam, your stroke exam, not an ultrasound of their belly. Now, let's think about this how we normally would if we were sitting in front of a patient on the truck. If they're diabetic, we're thinking hypoglycemia, right? He's just confused, we'll transport and monitor.
So you check his sugar because you're being a, provider. Normal glucose does not close the case. So you check it, you're like, I think this blood sugar's low. It's not, which should honestly scare you even more because now it just removes your one simplest answer. So glucose check obviously is always required in a stroke assessment, and we all know why. So a normal glucose does not exclude a neurological emergency. It actually makes you more suspicious. So what are you seeing? The first thing that you're seeing is executive dysfunction, and it's a cortical problem. So your signs are task sequencing failure, inability to complete actions, and delayed cognition. The patho behind this is you have some frontal lobe dysfunction, early ischemia or pressure effects, and the neurons are failing before they're dying. This is brain dysfunction before brain death. So the BFAST stroke exam, there's some limitation. So it uses a screening tool, but it does not capture all stroke presentations. BFAST finds strokes, but it also lets some slip through. So diving a little bit deeper into the patho, you have some possible causes: your ischemic stroke, your intracranial hemorrhage, and subdural hematoma. The key mechanisms are a decrease in cerebral blood flow, an increase in your intracranial pressure, and a decrease in neuronal function. So there's a perfusion relationship. So your brain needs pressure and flow. When there's a disruption in either, then you have a cognitive decline. So what this looks like kind of in elderly patients is because their brain is atrophying as you get older, it can increase your bleeding risk. And subdural hematomas are going to be in a higher risk category for them, and they can present gradually.
Older patients don't always crash, but they do decline. All right, now let's get back to our scenario. So what we are seeing is this patient has increased confusion. They're starting to not be able to follow commands, and we start to notice, because we have done repeat exams, that now they have a very subtle arm drift. Okay, now it's starting to look like a stroke, but it's already been 20 minutes since we first made contact with this patient. Stroke recognition should be based on trajectory, not just a single exam. Early recognition improves access to reperfusion therapies, and delays, obviously, as we know, worsen outcomes. So let's talk about what this means for us in the pre-hospital setting. It is absolutely necessary and expected that you are reassessing your patient frequently, especially if there's a suspicion of some sort of neurological event happening. As far as ventilation goes, you want to maintain an end-tidal CO2 of 35 to 45. And yes, you heard me correctly. That is within normal limits. That is a normal end-tidal CO2. We don't hyperventilate just because they have a stroke. Okay? You still are going to maintain a target of 35 to 45. However, you should very much avoid hypotension and hypoxemia because just one episode of either or of those things in a stroke patient can double your risk of mortality. Okay, so this is a very serious issue. This is something that we've talked about on this show before, and how sometimes it can be hard to change gears if you've already kind of gotten into the mindset of one pathology, one disease process, that you are really putting all of your eggs in one basket for assuming that is happening. However, and I think stroke is a very classic example of this because hypoglycemia can mimic strokes, or sometimes you can be hypoglycemic and still having a stroke. That it is very important to be comfortable with switching gears. If you initially get to a patient who is exhibiting hypoglycemic like symptoms, you get their sugar up and or if they just have a normal blood sugar and they are still progressively having these symptoms, then you need to be able to switch gears and call that stroke alert. Don't create secondary brain injury while trying to figure out the primary one. So even if you aren't ready to hang your hat on, I am calling the hospital and I'm waking everybody up because I'm calling a stroke alert, you still have to maintain ABCs, right? So whatever your patient is presenting with at that moment, don't delay providing care towards their airway or their breathing or their circulation because you are trying to solve a mystery. Still treat your patient, and then wherever you land is where you land.
Oz and I talk a lot because we get a lot of weird neuro calls where it is not just this cut and dry stroke. Like, especially in school, a lot of times you learn these are the signs and symptoms you're going to see. They're going to be they're going to have facial droop. They're going to have slurred speech. They're going to have an arm drift. And that is 100% going to be a stroke every time. And we just get these like strange presentations where it's like a 40-year-old male that has a little bit of an odd gait, but has had a headache. And now what do you do with that? And you have to really start to think about the patho of strokes and what a hemorrhagic stroke versus an ischemic stroke and what that actually does to your brain, because then the symptoms start to make a lot more sense. So the clinical takeaways for this is that basically we're going to talk about the big five of stroke signs. So one is going to be sudden confusion. If somebody is normally awake, alert, and oriented all the time, and then just boom, they all of a sudden have no idea what's going on or where they are, that's a sign of stroke.
Which is not on the B fast, if you've noticed.
Yeah, not a lot is. Two is executive dysfunction, cortical involvement. So they can start a task but can't complete it, or they can hold something but they don't really know what to do with it. You'll see this a lot in patients where a physician will be like, what is this? And they'll say a pen. But if you give them the pen, they have no idea what to do with the pen. And that's an example of like an executive dysfunction.
Which is also not on the BFAST stroke exam.
A normal glucose does not equal a safe patient, which I feel like we're all pretty direct on. If their glucose is normal, but they're expressing stroke-like symptoms, that should make you more worried. If you get a hypoglycemic patient that is hypoglycemic and you check their sugar and you're like, oh, I can fix this. Once you do return that sugar to baseline, if those symptoms don't resolve, now you have your next mystery to set out on to try to figure out what's going on. 4 is that a stroke is not always going to be fast positive. So you can do your B-fast, you can do a Cincinnati, you can do an AH, you can do really whatever it is that you want to. People are not always going to be positive on those scales. And this is when we talk a lot about following the juju vibes and following your gut. If you feel like there is something off with this patient, statistically as pre-hospital providers, we're pretty good at identifying like this is not right. Go with your gut. I'd rather call it and be wrong than not call it and be wrong. So the last one is going to be trend. How your patient trends is going to be a lot more important than just like your initial encounter with them. And so if you spend 20 minutes with your patient, you might recognize that cognitively there is a delay or things aren't clicking or they are not able to complete said task. This might not be super obvious initially, So yeah, spend that time and really kind of paint the picture of that trend and not just like one clinical snapshot.
So back to our patient. He didn't crash. He didn't seize. He didn't have facial droop. He just slowly lost the ability to think. And if you're not paying attention, you will miss it. Not because you didn't care, but because you were waiting for it to look like an emergency. Jasmine, thank you for trusting us with this call. And if you have got one like this, a call that didn't sit right, a patient that you're unsure about, submit it using the link in our show notes. Because the calls we learn from most are the ones that didn't feel obvious.
See you later, bye.
If this episode brought you value, take a moment to rate and review the show. It helps more providers find us. Follow Life in Sirens, join our mailing list for exclusive content, and visit lifeinsirenspodcast.com for resources and downloadables built for the modern provider. And if this conversation made you think, send it to your partner, your preceptee, or someone on your crew, because better providers build better systems.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.